Hello, my name's Toby Baring. I'm one of the orthopaedic surgeons at OneWelbeck, and I have a specialist interest in shoulder and elbow. Frozen shoulder is essentially an idiopathic condition of the shoulder. And that means that it essentially is a random event. We do now know that it has a strong genetic component because most people who get a frozen shoulder on one side at one point will get it on the other side as well. And more recently we have actually discovered a frozen shoulder gene. It is a scarring up of the capsule, which is the deepest layer of tissue in the shoulder. This is a layer of tissue below these, which are the rotator cuff tendons. So the rotator cuff itself is not affected in frozen shoulder. Normally the capsule is a very elastic structure. In frozen shoulder, it goes through a scarring process and goes from being like an elastic band to being like a leather belt, and essentially starts to lock up the ball and socket joint of the shoulder girdle. So frozen shoulder can affect almost anyone, but predominantly we see it affecting females between the age of 45 and 55 in the perimenopausal period. Interestingly, as yet, we have found no association between frozen shoulder and the change in hormones seen with the menopause. But equally, it's commonly seen in men. Most of them are what we call primary frozen shoulders, and there's no reason other than the genetics, as I've already explained, but we do also see it after trauma, even minor trauma to the shoulder, and quite often after surgery to the shoulder. The frozen shoulder can present in many ways, but it's basically over a period of weeks or sometimes months, the shoulder gradually loses its range of movement. Now that may not be noticed by the patient initially, and quite often patients present thinking they've injured it during exercise class or reaching for something typically around the back seat in the car. But that's just them stretching their shoulder out to the point where it started to tighten up and restrict the range of movement. It also has some other very typical features. Nighttime pain is very common, and that is most nights, and it will wake you up for potentially quite prolonged periods. We also get this what I call sudden movement capsular discomfort, where if you get jolted or you move the shoulder suddenly and pull the capsule to its full extent, that can be very painful for up to 20 to 30 seconds. So frozen shoulder these days is thankfully treated with a combination of injection therapy and physiotherapy. The injection we typically tend to use is called hydrodistension. And essentially this is done by using ultrasound guidance, so a little ultrasound probe is put on the shoulder, and then under the scan we can guide a needle into the glenohumeral joint, so that's into the shoulder joint itself, and inject a combination of water, steroid and local anaesthetic. The water is injected under a bit of pressure, and that helps to stretch out so it blows up the capsule like a balloon and starts to stretch out the scarred tissue and break down the scarring. The local anaesthetic makes the procedure quite comfortable, and the steroid has a strong anti-inflammatory effect, which can be very good in terms of controlling the pain. This then needs to be combined with physiotherapy, and we tend to refer patients on for what we call a capsular stretching program, and I'm now going to show you a few exercises you can do to help with that process. So there are essentially three planes of movement in the shoulder, and these stretching exercises address those three planes. The first one is to regain elevation, and that's done by crawling your arm up the wall and then leaning your body into the wall. That can also be helped by finding something quite high up to hang off, either a door frame or a bar, and then essentially hold on to that and start bending your knees, and that allows you to put a bit of your body weight through the shoulder, and that's a very good stretching exercise. One of the other planes is external rotation, which actually down here is bring your arms out, but actually it is equivalent to linking your hands behind the head and pushing your elbows back. And that again can be done by placing your elbow against the wall and pushing your body in towards the wall to help push your elbow back. And then the third plane of movement is what we call internal rotation, and that's bringing your arm round onto the base of your back and pushing your hands up your back, and you can do that by holding onto something behind and bending your knees to push the arm up. In terms of when you should come and see a specialist about your frozen shoulder, well, if you are experiencing symptoms as I've described, and that's mainly restriction in range of movement, and your function has been affected by that restriction of movement as well, very disrupted nights, and a lot of pain when trying to use the shoulder in more extreme range of movement, I would recommend that you should come see a specialist about some sort of intervention, as I say, usually in the form of injection therapy and physiotherapy.